Sort of, I think one final question related to this. In shifting, you had mentioned this in an earlier point about potentially like having to trust your clinician as well while you're going through this process. Given that everything has really dramatically shifted to being this sort of like telehealth mode, you're losing a lot of body language. Do you find that it has potentially been more difficult to establish trust within teletherapy compared to, let's say, an in-person modality? And how do you think that might have impacted like patient progress?
Yeah, I wouldn't say that it's more difficult. I do find though that when I'm meeting a new patient, we're starting in a different place. It's an even more impersonal place to start with. So we just have further to go versus maybe some patients who I do still work with, we might have met in the office where we had known each other for a couple of years. I think that it was a lot easier to kind of connect sooner, get to know each other a little sooner because we just had more information about ourselves. Like you mentioned, body language, the way an office is, the way a waiting room is, even just the process of intake, like all of that, I think spoke to a clinician or a patient's approach to that or approach to a new relationship. So now so much of this is just over a screen, and what you're seeing today is what most of my patients see. And there's a lot to overcome there, a lot to communicate in terms, like I mentioned before, trust and warmth and connection, what it means to be real. So again, not difficult, but just I put a lot more intent, I think, in how present I am, at least at the beginning of working with a new patient, just so that they see it, they see it, they feel it. The other thing I think is also important is to address it, because let's be real, we're seeing each other, meeting each other over a screen, and for so many people, I'm never going to know them in person. That doesn't make our relationship any less special, any less therapeutic. But let's talk about really what it's like to pour your heart out to somebody over Zoom, and what it means to feel a bit removed from that. And maybe if we can talk about it, we can overcome it.
And one more thing, we sort of addressed this, but it's a tough question because it's a question about, I guess, trade-offs, is in terms of disadvantaged groups. Do you think that the shift to telehealth, or I guess the option of telehealth, is primarily an advantage or a disadvantage to said disadvantaged groups? And obviously there are factors that lean in both directions.
Yeah, I have a hard time with primarily. I'm not sure if I can say one or the other, but clearly there's both. Like one is that, like I was saying, yeah, we did touch on it, that it has helped alleviate some issues of transportation and scheduling, childcare, even just kind of like the dependability of getting to session. But, and I saw this when I was working at a community clinic, while some of those issues had been alleviated, it brought on a whole new set of issues: access to technology, stable Wi-Fi, even just like a general knowledge of setting up a telehealth appointment. Like so much of that had, I think, set in as an obstacle to treatment, which in itself had to be addressed first before doing the work. I think also, and this is something I often speak about too, even with my patients, is I was so accustomed to providing a safe space for patients. Like, this is the office, this is where we come to, this is a calming, neutral space. And for a lot of people, especially given what they're going through, the sources of their distress, we are now placing the responsibility on them to create that space for themselves to do this work. And I can't say that that's always possible, even week to week. Like, I can't tell you how many sessions I've had with patients who are sitting in their cars because it's the only place that they can really do some of this work and let themselves feel. Or how many sessions I've had with a patient who has their headphones in because their child is sitting on the couch watching TV, and they need to kind of be with them, keep an eye on them, but of course also do this really important work. So those are new issues that we didn't really come across, at least not as directly, before a couple of years ago.
Changes, but our way to adapt. changes. And I can't say enough about friendships with people in the profession.
Yeah. I was wondering, have you seen the pandemic affect your, I think one of the things that we all had in common during that period was the sort of loss of social support in some form. So how have you seen the pandemic like altered your own views on how it impacted your perspective on treatment and sort of that connection that you're referring to?
Right. It was very hard to tell people who were already, because of their own personality issues, isolated, to suggest to do what we just talked about here. I have a man who's very phobic before the pandemic, very phobic, frightened of germs and illness. And he said, can you imagine what it's like for me now? And I couldn't. So to say to him, meet a friend for coffee, it was unlikely, you know. That, I mean, if I was reading something from APA, you know, before you guys got here, because I thought I saw it, I thought it looked interesting. 140,000 children have lost a parent or a caretaker in the US since this. 100,000 people have died of overdoses. In many parts of the country, a child brought for mental health care, it takes 4 months to get an appointment. This would be inconceivable with a cancer diagnosis. And yet that kind of isolation is occurring even just in terms of healthcare, forgetting what is that a symptom of? It's a symptom of, and I don't know if you've done something which I've started to do again called driving a car. Do you see how people are driving? I don't know if you've noticed. They're driving like they've been let out of a cage and they're enraged, cutting you off and driving, you know, tailgating. And I think the culture is just exploding, you know, with all this pent up.
I guess on the side of the patients, we noticed some discussion around people either developing routines that were very new to them or hobbies that were new to them and that becoming an important part of their identities, or people having sort of surprising identity or personality changes that resulted from the pandemic. Can you speak to either of those?
You mean people who I've worked with?
Yeah, so patients, this obviously the pandemic having like a serious personal impact on them and
bringing them into themselves in a way that something good came, another hobby. Or,
ideally good, yeah, but not necessarily.
I see. I didn't see that. I did see, I did have the experience I've had in the past where particularly people who I've worked with who went on into medicine, people have contacted me and I thought the metaphor was they were calling to see if I was alive. But people who came back not to see me, but to check in or to have a session. And it centered around either they want to know if I was okay, which sounds a little egocentric, or they were also something about the pandemic had triggered what had happened in the work with us. And typically it was a couple of meetings and that was enough. I think I'm unusual in that, not that the pandemic didn't take a very big toll on me. It cost me 2 years and I'm old. So I wasn't, nobody can afford to lose 2 years, but it was particularly distressing to me. I did write a book and complete it and work on another. So I got myself involved in something that would, that would keep me feeling, my work makes me feel a sense of meaning and purpose. And that's why I'm almost 80 and I'm still 80 years old and I'm still working. So, I fell back on defenses and personality traits that have worked for me. I think that changing personality is a very, very big process. It means that there's been a lifetime of certain kinds of coping mechanisms, which we actually call defenses, although it has a very different meaning to the lay public. You know, the kinds of defenses that one would use as a young child, which is, you know, if something's upsetting you, you don't want it to bother you, you close your eyes and go to sleep. In adults, we do some version of that. The phone rings and it's bad news, and you say, oh no. In that split second, we've regressed back to closing our eyes and making believe something isn't there.
In terms of that, I was wondering if you might speak to a little bit about the way you've seen intersectionality potentially play a role in your client's experience during the pandemic. So for example, how have you seen the intersection of like gender, race, ethnicity, or culture impact that sort of experience they've had during the pandemic? I know that's a really big question. So if you need some time to think about that, please do.
I mean, where I'm struggling with answering the question is that intersectionality and all the identities that they hold is affecting every part of their life. So I'm trying to see what would be different in terms of the pandemic. I mean, I don't think that there is a major difference in the way, when I'm talking about, and I'm talking about, I guess, exclusively like therapy, but I can't speak for before the pandemic because I wasn't doing therapy then. But I can think of sort of a mark moment or a marked example that I can point to that says, oh, this is where intersectionality has sort of come up. I think it always comes up. When we talk about access to therapy, when we talked about kind of having like resources and knowledge about therapy that has, you know, that it's rooted in, you know, actual science, or, you know, not just like beliefs, that the cultural beliefs that they have. You know, trust in the institutions. We're talking about like educational systems that are still playing, like, are they providing like the actual care that these parents need? Are they providing resources? Are they just like referring their children out? And what does that mean? Are they giving them information? A lot of parents that I call, they have very minimal information about why their children are being referred out, or they have an inclination as to what the reason is, but they don't really understand the therapy and what it entails. And, you know, we're talking also about like different things like gender, sexuality, religion, beliefs, and all of that just plays a role into how they perceive therapy, how they approach, what the expectations that they have. And again, like just talking about access. And not only access to therapy, but also access to other supports that they would need. So there are a lot of times where I find myself sort of like stuck because there's only so much that I can do in therapy if there are so many other factors in the child's life that they need some help with. And, you know, yeah, we talk about being okay with being uncomfortable, and we know that we are not going to like solve everything in therapy. That's not how these things work. But, you know, when a child's telling me like, oh, I want to have like dance classes because I think it would make me happy and it would make me less depressed or make me cry less, but they don't have the resources for that because there's no money for the dance classes. The parents cannot take them to that. It's like, what can you do? Right. And so that is like where sort of I can see that sort of playing intersectionality. And, you know, thinking about some specific clients, like not a specific clients, actually all of them, but there's a specific client where it's things related to sort of religion, sexuality, and like the culture has definitely come up. There has been a lot of tension because there's differences in how they're viewing these things, right? Like the religion is saying that their sexuality is not okay, and sort of how the culture is playing a role into that, also like the gender identity. And so there's been a lot of those things that are going to come up and that continue to come up. But I wouldn't like, I don't know that it would be exclusive to COVID. I don't know if I.
No, that absolutely makes a lot of sense. Thank you for pointing that out. I think there's this idea that essentially, then there's some statistics surrounding this, that disparities did increase during the pandemic, including like rate of accessibility, and like these fractures that already existed got exacerbated. But it's really interesting and poignant to hear you say that it's always there and it always comes up, pandemic or not. So yeah, thank you for bringing back that focus, that these issues are real and exist.
Since we're kind of focusing a lot of these videos on people who are already in the field, but also a lot on people who are training and they're thinking about like their path. One of the things that you brought up, and one of the questions that's brought up for me about disparate access to like mental health care and some of the barriers that we encounter. I know you mentioned that, you know, obviously like as clinicians, we can't solve every problem, but if you have any ideas on what clinicians in the future and now can kind of do at an individual level to help kind of break down some of those barriers and like the lack of access to resources, but not just at an individual level, but also what should be done maybe at an institutional level as well.
That is a great question.
I know it's a big question, so
yeah.
Like, however you want to take a second.
I think I have a little more thoughts about individually, and I guess I'll come back to the system as a whole. I think individually, I can only speak as a trainee right now. And I think is listening is one thing, like listening to what your clients need, asking questions about what they need. And, you know, using the resources that you have, using the knowledge that you have to advocate for them if necessary. So, you know, an example comes to mind of a parent who wanted to take their child out of pre-K because she thought that, you know, they were sort of targeting her, you know, and she was very distressed about it. And, you know, I said, look, let me talk to the teacher. Let's see what's going on. And, you know, I was able to sort of like talk to the school, talk to the teacher, and sort of help the parent, like sort of navigate that a little bit. And we are still in the process of navigating that and seeing what was where did that rift or where did that miscommunication come from? And, you know, helping her sort of navigate that. And so that is one way that, you know, I feel like I could advocate on an individual level and just like listening to the parents and helping, you know, in the way that I could. I think, you know, there are limitations. There always will be as an individual as to what you can do. There are some times where you think you're doing the right thing and sort of the client themselves are like, no, this is not what I wanted. Or the parents themselves are like, why would you do this? And so you do have pushback. I think as long as, you know, you are being culturally humble, you're sensitive to the needs of the clients, you're listening, and you're also communicating with them like, look, these are the options, this is what we can do. Do you want to, and trying to sort of collaborate and communicate with them. And I think that's as much as I can think of right now as a trainee, because as a trainee, you have less, you know, you have less power and you have less, you know, opportunities to sort of like maybe advocate in a way. But I do want to bring it a little bit outside of therapy. You know, as a trainee, you also have your peers in the programs, you know, and you're going through all these experiences together. And when someone, you know, you're also listening to their stories, and you learn from your peers. It's very powerful what you learn from your colleagues and the people who are in your cohorts and the people who are in your program. And they all have their stories to share, and there most likely will come up a time where they share it. And if there's a moment when you're noticing something, you're sort of noticing a disparity, you're noticing that there's maybe like something that's being said that is inappropriate, something like a microaggression, you know, what can you do as an individual is try to support that individual, but also speak up against those things, especially when, you know, you have the ability to, and you have the energy to. Sometimes it gets emotionally taxing to be the person who is like at the receiving end of it. And so if you are listening to these things and you have a voice, use it. And there's a lot of power in numbers, you know, talking, we have the ability to talk to our supervisors, we have the ability to talk to like directors, and things won't get done unless somebody brings it up. And I think, you know, that there's another way that you can advocate for yourself, for your peers. And, you know, it's a good way to sort of also think about how you're going to advocate for your clients in the future. You know, when it comes to legislation, when it comes to laws, like, are you going to, what can you do in the future once you have your degree, once you have your practice, once you have like to help, you know, advocate for mental health, for people, you know, underrepresented communities. And so that's sort of what I'm thinking about as you're answering that question. I guess, you know, that sort of ties into like institutionally, what can we do? Well, you know, being mindful of what you do individually is going to ultimately help as an institution if you are, you know, speaking up and you're doing your best to sort of be knowledgeable, you're being your best to support. And I'm thinking about actually Dr. Gold's story, where, you know, I don't know if he shared it with you all, but he had shared about how, you know, he tried to advocate when, you know, legislation or something was going to come up. You know, he went there with another psychologist to try to advocate for that. And so that's what I'm thinking of.
Yeah, that was a very hopeful answer. Like, I think like I'm definitely just going to carry that also with me as I like continue my training as well. So thank you. I think it, and correct me if I'm wrong, like one of what I got from that is just that, you know, it's important to just maintain like a stance of curiosity with these clients, to check those kinds of assumptions, and to just see like what is it, where can like I also collaborate with them in terms of like your role is also to be an advocate. And then one of the themes that we've kind of come across in speaking with some other people about this topic is how in the pandemic and just in general, this theme of like it being a parallel process, that, you know, so a lot of these issues, like it's not just located in the therapy room and it's not just located within the client, but it's also going on with clinicians. It's also going on outside of that. So it's important, I guess, like also to just maintain that stance of being an advocate, of practicing the same way that you would want to practice with your client, but also just in your everyday life, within your institution, with your peers, and at a broader level in terms of trying to bring about institutional change by, you know, collaborating with others and bringing people together to have that advocacy voice.
Yeah, you said it much better than me. So yeah, that's